The webinar is on, Jen.
Today, many millions of people around the world fear vision loss. And for some people, even the loss of a limb, is less fearful than losing their vision. My name is Jane Barrett and I'm the Secretary General of the International Federation on Aging. I'm delighted today to be moderating the first of a series of webinars. The title of the webinar is From Evidence to Action, Good Practices from the DR community, the Diabetic Retinopathy community. So let me tell you a little bit about this webinar today. The Diabetic Retinopathy Barometer Program is a global action network of individuals and organisations, and we're working to improve vision health outcomes of adults with diabetes. We do this through interdisciplinary collaboration and knowledge exchange. And today we have three key experts in the field, and they're going to be talking about the DR Barometer Program, including where it came from, its accomplishments, and its new initiatives. We're also going to hear from an expert introducing the Vision Academy as a new partner in the DR Barometer Program. And finally, we're going to hear from an expert from Germany about examples of best practice in DR-related work. I'd like to introduce each of them now. So following my brief remarks, Ms. Michelle Savanovich will be talking with you, providing an overview of the DR Barometer Program. Michelle has really been one of the drivers, almost maniacal, obsessive in driving this program of work. And the IFA is delighted that we've partnered all the way together with IAPB and IDF. Michelle is the Director of the Global Advocacy Ophthalmology at Bayer. The second speaker will be Dr. Aslam Tariq, Dr. Tariq Aslam, consultant ophthalmologist. He's going to be talking about the Vision Academy. And our third and final speaker is Professor Volker Zaimson, consultant ophthalmologist at the University of Tübingen in Germany. So it's my great pleasure to hand the microphone over to Michelle Savanovich, Director, Global Advocacy Ophthalmology at Bayer. So take the floor, Michelle. And before I hand it over, thank you for being that driver, for being that person that challenges all of us and pushes us to do the best that we can. Thank you very much.
Thank you, Jane, and thank you to the IFA for hosting this webinar. It's quite exciting to see us go into this next phase of the DR Barometer program. And as Dr. Barrett had stated, it really has been a collaboration across sectors. So thank you for giving me those accolades, but I have to echo them back to IFA and yourself and the other partners, because it's really been a journey that we've kind of stepped on, embarked about 2014. And I'll speak a little bit to the history of the Barometer program to give those who are attending and haven't really been informed of the background, just to kind of bring everyone up to speed as well as to what did we do, why did we do it, and what did we find. Next slide. So just as a background, diabetic retinopathy is a condition that affects people living with diabetes, and it really is it's an eye condition where I won't go into the details of what happens because I'm not the medical doctor, but essentially as diabetic retinopathy progresses, it will turn to diabetic macular edema, which then becomes sight-threatening and is the leading cause of blindness in the working age population. Here we see actually it's a global issue. On average, 1/3 of people with diabetes have diabetic retinopathy in some form. And of course, in countries where you have a higher incidence and prevalence of diabetes, you will also see a similar correlation to diabetic retinopathy. Looking at Mexico with around almost 40%, South Africa actually topping over 63% are living with some form of diabetic retinopathy. Next slide. So not only is this a global issue, it's also an individual issue. When we look at any person living with diabetes, regardless of your location, the chance of getting some form of diabetic retinopathy is correlated to how long you live with diabetes. So if you're living over 20 years, actually those will have, 75% of them will have some form of diabetic retinopathy. So we see this both as a global individual issue, but then if you overlay it with the impact of the rising rates of diabetes, and then the benefits that we've made in healthcare advances, but that people are living longer, so the older aging population shift, this is really then becoming one of those unfortunate perfect storms where actually we're going to see these numbers only increase. Next slide. So this is why in 2014, when we started looking at this challenge and unpacking it, we quickly realized it is not a singular responsibility on one organization or one sector. And so it was really about bringing together the multi-sectoral collaboration. And here, as Dr. Barrett and the IFA, you're familiar with, but representing the aging kind of population and ensuring the rights and functionality. The IAPB, which is the International Agency for Prevention of Blindness, they're looking at vision issues and making sure that vision preservation is key. The International Diabetes Federation looking at the care for people living with diabetes and the healthcare providers that watch over. And then the Vision Academy, which Dr. Aslan will speak to, but this is also 80+ retinal experts that really have an interest in this area and improving care for people living with diabetic retinopathy. And then Bayer, where we stand, actually also providing therapies and treatments, but also we wanted to actually go back at the very beginning and try to prevent as many people from needing therapy. So we've combined together to form the DR Barometer, and it's really our main goal is to shift the needle in improving outcomes for those living with diabetes. Next slide. So with this combined mission and vision where people do not need to experience preventable vision loss due to diabetes, next slide, is kind of our core theme, and that really is grounding us in all that we do and work together, and why it has made such a nice partnership, because we all have the same end goal. So the evidence to action is really where we started. With any difficult challenge, you need to go back and ask the right questions. So we'd said that first and foremost, we need this to be based on evidence. We need to know what's happening for our people living with diabetes and the healthcare providers that treat them. We then need to take that evidence and engage all stakeholders that have a touch point and really come together as a community to define how are we going to intervene and provide support. So then we would look at doing that and bringing driving actions through communities of practice. And so Jane and will speak to this a bit more, I believe, but a community of practice has really joined up interest individuals who are looking at challenges and developing solutions. Next slide. So I just quickly want to touch base. This is all available on the DR Barometer program if you wanted to dive deeper into what the evidence did show. But we did 2 multi-phase study. We did interviews in 8 countries, both people living with diabetes progressed, no vision complications, progressed all the way through to blindness due to diabetic macular edema in 8 countries. We also did this, and we also interviewed their HCPs, from a diabetologist all the way through our GP, nurses, retinal specialists. And we actually took that findings and developed a bigger survey, which we launched online. And this was the quantitative survey. We launched it in 41 countries and had over 7,000 respondents. From that evidence that we pulled of both studies, we actually were able to identify 9 key barriers where either patients or healthcare providers said was a gap or a barrier, a hurdle that needed to be overcome that could have an impact. And so we kind of mapped that along the care pathway. We then took that information, and this is where we brought it to actually experts workshops, and this is when we engaged our stakeholders. Next slide. During these workshops, we held one in Berlin and one in Europe. One in Europe and one in Latin America. And there we really worked across disciplines. We had patient organizations representing the 3 different focus areas. We had frontline treaters, retinal specialists, we had health economists, we had governments, etc. So really tried to bring it together, all different perspectives. From there, we distilled those 9 key barriers to define what are the 3 succinct areas that we feel, if we had worked towards interventions, will have the biggest impact, that we can develop meaningful, targeted interventions to really shift the needle and change the outcomes. And so here, the first tranche that we really wanted to focus on, and this is where the communities of practice, there are 3 focus areas. The first one is around ensuring education, engagement, and empowerment of those people living with diabetes. But from the HCP side as well, it was improving uptake of guidelines and protocols. And then thinking about a holistic care system where the patient is at the center and not going to each individual, trying to manage their own care through each individual system, that actually we needed to create this cohesive system and coordinated patient approach. Next slide. And I want to briefly talk about some key data points, because why? Why did we think these were going to be, why did these come out as the most important? Everything, as I said, has to come from evidence before you act. So next slide. This is where we kind of come with, was the biggest telling slide. We asked our retinal specialists in the quantitative survey, what's the greatest challenge? And everyone succinctly said 66% late diagnosis. Patients are coming in already with diabetic retinopathy or worse, vision-threatening DME. But actually, if you move forward one slide, it will bring up an animation. We challenged that and actually turned it on its head and said perhaps late diagnosis is a byproduct of all of these other factors. So if we look at these factors a little more in depth, can we change the outcome? So if you, next slide. Patients, we asked if they, what complications they were aware of across all the different complications, and actually 85% of patients were aware of vision loss through diabetic retinopathy, and it was actually the most widely known. Next slide. Not only were they aware, but they were actually extremely fearful of this condition. This was the complication they feared most. They feared it more than 2 times of having a stroke or loss of limb or actually kidney failure. So they were aware and afraid, but how did they weren't empowered. Next slide. Actually, where we see this was in the qualitative study, when you go down to really what the people were thinking. And this quote kind of captures it best. So they're aware, they're afraid, but they're not empowered to know what to do. How did they take then their proactive effort to change the outcome? Next slide. And this is where we come into a knowledge paradox, where we actually ask the people living with diabetes where they got their information to be empowered, to learn more and what to do. And we ask the difference between general diabetes information and diabetic eye disease. And if you see across the board, there's obviously more information available about diabetes, which is understandable, but where they get their information from, the doctors having the available information, only 50% actually got their info from there, with the internet and diabetes organizations closely behind as key areas to provide that necessary information. Next slide. But it's not just about, okay, the doctor didn't give it to me, perhaps it's more the doctor didn't have it available. So we asked on the other side, the HCPs, and actually only 34% of the doctors, over 2,000 doctors, said they had sufficient information to provide to their patients, whether it be the frontline treaters or even the ophthalmologist retinal specialist. So this gap in information, available information, is a critical one that we can really change quickly and get the information in the right hands. Next slide. And it needs the correct information, because this is all needs to be based again on standards, guidelines, and the best recommendations. So when we look to the second COP topic, which is around uptake of guidelines and protocols, actually only 44% of those that responded, doctors, had the protocols and guidelines and use them in their practice. So there's a big gap here, which is also low-hanging fruit, because guidelines, protocols, this information is all readily available. We just need to ensure it's in the right hands and being applied. Next slide. The last bits around we looked at around referrals and why can't what's the difficulty attending exams, so which is then would relay into the late diagnosis. And the patients and the doctors had 2 different experiences and perspectives, of course. They did agree that cost to the eye exam was a barrier, so that is definitely something that they agree and we need to look at addressing. but actually the clinicians blamed the patients, saying it was a lack of knowledge on the patient side, and the patients blamed the doctor's office that it was the long wait time for appointment. And so it's really, again, this kind of pulls into this coordinated care and thinking about how do we easily get patients to access these eye exams at cost-effective rates, and also how do we ensure that information sharing is available, but patients aren't stuck in a system, that they can quickly get to what they need in a way that's least barriersome for them. Next slide. Because in the end, what we want to do as well is improve screening, because if you can actually catch screening early and you have regular screening, then then you can actually prevent or reduce your risk of having the onset of diabetic retinopathy by certain interventions beforehand. So it's critical the patients are getting in appropriate time for screening, because here the retinal specialists, again, 65% of them said the majority of their patients, or everyone they see, actually attend when problems have already occurred. Next slide. So my closing slide is, and why we chose those three main points is, you push forward one, is that we really believe with the Barometer community, if we can address these issues from patient education down to cost of care, that we really will have a major impact on the late diagnosis. And with that, I will take questions towards the end, and I hand it over to Dr. Barrett. Thank you very much for your time.
Thanks very much, Michelle. I think that you've really given us a fairly comprehensive overview of not only the evidence, but how we're trying to shift the evidence to action. And I think that's exemplified in the logo, the DR Barometer Shifting the Needle. It really is talking about trying to influence policy. At the heart of our work, and Michelle has introduced all of our partners, International Agency for the Prevention of Blindness, the International Diabetes Federation, the Vision Academy, also Bayer. You know, what we're trying to achieve is a multidisciplinary, multi-stakeholder actions. And so to do that, we're using those three areas of focus that have come out of the evidence from the DR Barometer study. So protocols and guidelines, patient education and empowerment, and coordinated care. We're taking those three bodies of evidence, and now we're actually moving towards the development of communities of practice. And one may ask why we're working towards communities of practice, because we've found that, you know, it's by coming together and understanding what our common agendas are from different sectors and different disciplines, and what is the common key questions that we can ask that will deliver policy change. Could I have the next slide, please? Thank you. We are and are continuing to be a growing community, and that community is made up of individuals, experts, but also organisations. You know, IFA talks about, you know, those stakeholders that can influence policy, and they are governments, non-governments, academia, industry, and older people. So if we use that kind of framework, you can see it's the cross-sectoral and cross-disciplinary approach. The Community of Practice onboarding workshop, which will be happening in Zagreb, Croatia in March, will bring together, you know, nearly 40 people from various countries of the world to come together to actually start the work on the communities of practice. You know, determining what that productive inquiry is going to be, what questions need to be asked to actually respond to barriers at a national level. I think it's important to say that barriers differ from population to population, but also they're very much in a local setting and sometimes within country. So for example, in Italy, you know, there may be different problems that we need to address within the different regional areas. Next slide, please. So what is a community of practice? And everybody can read that's on this webinar. But perhaps some of you are on phone, so I'll just briefly go through it. You know, there is a general understanding that motivated people come together and work on common agendas. And that's what COPs are. You know, at the core of it is collaboration, but an agreement around what is the productive inquiry. What are we going to inquire about, and how do we take the evidence that we know into an action? So we talk about experts and expertise coming together to influence and shape policy. And that certainly is at the heart of our COPs. We also talk about from global to local. And we were very pleased to be with IAPB at the WHO just last week when the resolution on vision, you know, passed the executive board. So we're taking from the global plans and actually building it into what are the key inquiries at a national level. So we would expect, you know, following the Zagreb workshop to actually have 3 fully functioning communities looking at different inquiries, different questions to ask in each of those communities, and then to deliver, you know, editorial papers, action plans, and other tools that can help NGOs as well as other members of civil society, you know, on the ground. Already we have some interesting questions that are coming up, you know, one from Mauritius, one talking about publications and surveys, etc. So I will wrap up now by saying that we have moved from studies where we've actually gathered evidence, we've brought key stakeholders together. Now we're going to actually use different methodologies to take the evidence and pull it through to action. So thank you. And I'd like to now hand the microphone over to Dr. Tariq Aslam, consultant ophthalmology, and he's going to talk with us about the Vision Academy. Thanks, Tariq.
Thank you so much for that. It's all really interesting. I am talking over from the United Kingdom, although not quite as united as we used to be. And I'm really grateful to the IFA for hosting this, because I think in these times, collaboration is even more important than ever. I was first asked to join the Vision Academy a couple of years ago. And I didn't actually know anything about it at that time. It sounded like, to me, like a group of superheroes. So I immediately said yes, and I'm going to talk today about what that group is doing and how they are making changes to things. Next slide. There's 3 main concepts that I'd like to introduce to you, which underlie the importance of Vision Academy. The first is, as we've already been hearing, that retinal diseases are the greatest cause of vision loss in the Western world. Next slide. Thankfully, there have been masses of new developments in medicine and imaging that have revolutionized care, where a decade or 2 ago, there were very few treatments in comparison for diseases like diabetic retinopathy or macular degeneration. Even in the time that I've been training in medicine, this has been completely revolutionized, and we now have some fantastic treatments that have completely changed outlook for patients. Next slide. One of the problems is, though, that remains is that with answers to many of the questions, like the best ways to treat somebody with diabetic macular edema, come a whole load of extra questions. When should you treat? How often should you treat? How exactly should it be interacting with things like laser treatment? And where we'd normally look to answers for these questions would be published literature. We all know that evidence-based medicine is the way to go with all these. And so naturally, looking for answers to practical questions, we would look at the literature. But the problem is that this field is so broad that even if you were trying to, you couldn't really go through all the literature. So just in the last 5 years or so, in the field of retina, there's been over 32,000 peer-reviewed papers. And so trying to answer these questions all by yourself is going to be really, really difficult. It would be like reading all of Donald Trump's tweets and trying to interpret what he's been trying to say. And so this would be impossible. So next slide. What the Vision Academy tries to do is to provide guidance on the best clinical practice from a whole range of experts who spend a long time looking at all the papers and coming to a consensus to be able to advise others where they might not be able to otherwise have their questions answered. And so this is a sample panel, and it is actually something like a group of superheroes to me. Jane Barrett is there on the bottom left. She's our Captain Marvel. And you can see that we have quite a diverse group of people from all over the world, Russia, from Italy, from the UK. It's diverse in terms of ethnicity and backgrounds and gender. So it's a group I really enjoy being a part of. Next slide. We meet regularly, and our mission statement is essentially to provide ophthalmic specialists with a forum so that we can share our skills and knowledge and try to build best practice. And some of the questions that I find that the Vision Academy answers are very brave ones and difficult to find in the literature, or B, even at conferences. Next slide. So we meet face-to-face, and we debate a variety of different issues. Next slide. The day is when in the meetings are taken up by lots of different functions. So, for example, we have work streams of trying to answer difficult questions. So, for example, here we have the example of principles of anti-VEGF treatment regimens. We don't just try and answer a question and then leave it there, but we try and go back to it and update it with new evidence. So some of the questions, such as additional measures of visual function beyond acuity, are questions that are really important to research. Other ones are really important to absolute basic down-to-earth practice of patients, such as the lower one in terms of simplified recommendations for the management of diabetic macular edema. Next slide. If you go to the Academy website, you'll see lots of different areas where you can get the results of this. And I put this slide up because top of there is a key statement, which is patient-centric care. And this is something that I think runs through the whole of the Vision Academy, where we are always trying to look at evidence and trying to look scientifically at what's robust and try and give robust evidence-based advice, but always the patient is at the heart of our practice and at the heart of all the advice we give. Next slide. So example questions that have been answered are things like suspending treatment of macular degeneration, being able to coordinate care in diabetic eye disease, giving bilateral anti-VEGF treatments. These are all questions that you wouldn't be able to find necessarily in the literature. I talked earlier about there being so much literature, but some of the questions we asked just aren't even there in the literature. So, you know, how many people give bilateral anti-VEGF injections at the same time, or factors affecting compliance are really hard to get. And so this is where the Vision Academy has a really, really important role in looking at these issues. Now, if you go to conferences, you sometimes get these questions addressed, but rarely do they come out with an answer at the end of a symposium that the Vision Academy does. So I'm really proud that the Vision Academy actually comes out and has a statement at the end of things which provides what we think is the best answer to these difficult questions. Next slide. How do we answer these? Well, sometimes we have research papers, so the role of OCTA in retinal disease management. Next slide. Sometimes we have slide decks. So this is a slide deck talking about recommendations for the management of subfoveal hemorrhage. If you look at the literature, there's lots of arguments about what the best way is, and what this slide deck does is give you at the end of it, looks at the literature, but then gives at the end a recommendation. Next slide. And this is the example of the research paper on the role of OCTA that came through the Vision Academy. Next slide. Other things that we do, apart from producing these guidelines and best case evidence practice advice, recently the Academy has been approached by the Lancet Commission on Global Eye Health to take part in a study which aims to identify grand challenges in global eye health and thereby bringing this issue to prominence in world acknowledgement. We have educational interests. So, for example, recently we have had a session whereby the Vision Academy has tried to invite younger ophthalmologists into the group for education and training. Next slide. Next slide, please. One of the last things I want to talk about is the Vision Coach pilot. Now, this is something which was an initiative of the Vision Academy, and I haven't yet been able to use it in my own clinical practice because of limitations from our own IT department, but it's something I hope to use shortly. But just to give you a brief overview, it's a strategy and an effort to try and help clinicians work with patients and to improve their engagement in their own care. Essentially, clinicians will be able to invite patients via a web app, and patients can see their treatment plans and record their visual acuity and things like OCT measures. They can add and monitor their own sight scores, and they can set lifestyle goals, and this way prove their own habits and track their own progress. Next slide. This is an example of one of the screens from the Vision Coach where not only can you track your own progress, you can find out extra information about what's happening and correlate that with the treatments that you're getting and what's happening to you in hospital. Next slide. And this is the patient side of things where you can access all this through a patient-centered app. Next slide. So to summarize, the Vision Academy, I did think of it, it sounded like a group of superheroes, and I'm really proud to be part of that group. I think they do really great work in answering questions and providing solutions where there aren't really any other alternatives that do it so well. It's a very multidisciplinary group, it's a very diverse group, and I think they give do a really good job in answering really difficult questions and really practical questions. And finally, doing it all in a patient-centered way is a really nice feature of everything. Thank you very much.
Thank you very much, Tariq. I found that very interesting for me. And perhaps I can also just say that the Vision Academy website is visionacademy, all one word, .org. You know, what struck me in your presentation is, you know, the constant discussion about how multidisciplinary this group is, and that's certainly true. And they're asking and responding to some of the toughest questions. And I know that I'm very proud to be part of it, and an unusual character. And I like the comment about Captain Marvel. Perhaps I'll tell my husband about that. But you know, I think in the forum, you know, we are asked to put forward difficult questions because it's the coming together of different minds, thought leaders, expertise, and, you know, the opportunity to agree to disagree. And I think it's in an open and transparent way. And that's something that we're really trying to, you know, create with the communities of practice. So thank you for that. We're now moving on to Dr. Volker Samson, consultant ophthalmologist in Germany. And Dr. Samson has really been one of the leaders in this field for quite some time, and the bio certainly demonstrates that. He's going to talk with us about the national perspective of vision health in Germany and introduce some of the DR-related work that his team's being undertaken. So thank you very much for being with us today, Dr. Zaimson.
Thank you, Jane, for the kind introduction words. So I think Michelle has really nicely pointed out many of the problems, and maybe we can start with the first slide where, next slide, please. So we are traditionally a small group of the scientific society, so of the association, and we are trying to increase the awareness and the detection of diabetes eye disease in general. And as we were aware in the barometer, please the next slide, we have similar problems also in Germany. Though we don't have a health system where you can really go to the physician and also directly to any ophthalmologist. You know, we have diabetes management programs where we have financial incentives to increase, nevertheless have a huge problem to have a good participation. So next slide, please. So half of all type 2 diabetes patients do not appear as ophthalmologist, is that is related to the insufficient knowledge about the disease. And next slide, it's also the knowledge about the symptoms. So every third develops diabetic retinopathy, but in a certain subgroup, we ask the patients for the questions. Then you move to the animation. We see that many of them did not understand what really is where is the retina, and on the other side, it was astonishing that still a large group, so 1/3, believes that there would be early warning signs when diabetic retinopathy arises. So on the next slide, we were thinking about, still it's not only knowledge, it's not money, it's the motivation, and it's mainly the awareness of the disease. And when we looked to the materials our patients with diabetes were exposed to, on the next slide, we were quite sad because these were not visually attractive. So these are examples of one early program, the Medias 2, but these images look quite similar when you go to on the international level. So on the next slide, we see some illustrations from the ADA program, and you to explain what really is the retina and diabetic retinopathy. I'm sorry for the sound. Please ask me if you don't understand something. On the next slide. We idea to really create new material to illustrate and to exemplify the problem. And show you on the next slide, our group is multidisciplinary, and we were thinking of moved images, and we did start with the trailer. Next slide, please. Next slide, please. So there were some ideas to in Germany. We have this term for the weaker self, which is called Schweinehund. So it's a mixture of a pig and hound, and it's something you want to overcome to get motivated, to get something, even though Germans don't have a huge sense of humor. We tried to pick this up and to trigger some patients really to care about their diabetic retinopathy. And see our hero of our campaign, of our video campaign. So next slide, please. And and as I said, we want to overcome the inertia with regard to the eye exam. On the next slide, we can see all those barriers too. So he wants to stay in bed, he wants to avoid trouble at work, he don't want to speak about his disease, and of course he has this thing in his free time and not to have exercise and all these other more demanding tasks. But next slide, we have those activities we want to show in an attractive fashion, and this was our trailer. We contrasted this first negative with the positive experiences. So on the next slide, please. In addition, next slide, please. Installed a homepage to have also the additional information next to this slide, please. So here you see the sitemap where you can really see the informations and the different. Also proud that we have seals of quality and transparency for this homepage, so that this is really focusing persons affected. Next slide, please. And in addition, we were thinking of more videos and more image materials, and Hero Martin to show to get the diagnosis of diabetic macular edema. And in addition, we can show you some animations on the next slides. Where we tried to diabetic retinopathy and diabetic macular edema. You can also so I think we can go over this, and you can get also an own impression by going just to YouTube and looking for diabetic eye disease, or in German das diabetische Auge, it's a German term. Next slide, please. So you can really see how the eye resembles a camera and really to explain. Okay. So next slide, please. I think we can, so this is quite similar. So to clarify where the macula is, and next slide, please. And these are available as YouTube videos, but also you can download these short animations from the homepage. Next slide. So I think in the interest of time, we can go just nation. So here you see where the mark get an impression of fluctuations of the systemic blood sugar. This is just to have visually attractive images and to get really a good impression what it. Next slide, please. Here we see an newly formed blood vessels, so proliferations. It's quite difficult to really exemplify and also the hemorrhage inside the eye. Next slide, please. Here we see a receptor to illustrate how VEGF and anti-VEGF drugs are working. Next slide, please. To the first slide after the animations. So if you are interested in these animations, they are available and you can use them, and also it's possible to adapt them in different languages. So next slide, please. So this is just an animation of an injection. So illustrate where the injection is taking place and to illustrate procedure. Next slide, please. So this is just a similar example of a steroid injection. So next slide, please. So this is an example of a laser treatment. Towards target and to clarify what is really going on during the treatment. When we, next slide, please. So when we evaluated the response, that nowadays the audience is not very patient, so they stop viewing the videos if we thought about shortening the videos and having also other qualities of information. Next slide, please. Got the idea to present this information not only on YouTube. Next slide, please. A really multi-channel approach with social media on Facebook, so to get a wider distribution and wider reach. Next slide, please. Next slide, please. So when we are audience, we have to think when they are listening to us. So we are using the free time in the evening to distribute different images, different phrases, different texts, different information types of information. Next slide, please. Post to have shorter parts of information. We are proud that we put involve an active customers. And next slide, please. We are happy that we are getting really a huge response, but to different types of posts. Next slide, please. When we fusion of our content, we have static and dynamic content, and we don't see a huge difference whether the users react to moving images, but we are getting also a huge response to static images. Next slide, please. Popular post was, for example, a cooking recipe, and what we also learned is two things: to have regular posts, and the second is that also the advertisements helped a lot to increase the reach and the awareness. Next slide, please. So next slide, please. Here you see an overview of, and you can get an impression that we really try to have a broad variety of different information. Next slide, please. Proud that we finally reached a large audience. So this is information of last week. Now they follows, and these are of course also still growing and having different contexts achieve really viral reach. To end up, next slide, please. I want to thank, wouldn't have been possible without Dr. Lipinski and Dr. Hermann, who are really quite active during the weeks. That every time we are, of course, also to the marketing people, to the agencies, and also to the animation guys and the cartoonists who produce the content. I think we wouldn't have achieved such a huge audience. So thank you for your interest.
Professor Zaimson, thank you very much. This is outstanding work. That's all I can say. You really have given our audience food for thought, and also to IFA and you know, the DR Barometer partners. We would welcome the opportunity of making links to these resources, and also talking with you about how we can you know, subtitle it with different languages. So that was terrific. We're really going to be pushing for time now. So rather than take some questions, and we've got a couple of questions, but I will make sure that the presenters see the questions and come back to them. I want to go back to each of the presenters, just with what is your single most important message for the audience here today. So Michelle, perhaps if you'd like to give your single most important message.
Thanks for the preparation time of 3 seconds to think about what is my single most important message. No, I mean, for mine, I think it's really about working together, understanding it's not a silo approach, and that each step we need to engage people living with diabetes, understand what motivates them, and engage the clinicians who are treating them to find each barrier that we can overcome, because we can't stand on our ivory tower and dictate the solutions. We really need to work together.
Okay, thank you. And Tariq? Dr. Aslam, are you there? You might be on mute.
Hi, sorry, I would echo what Michelle has just, I concur with Michelle, but also, you know, the patient-centered approach can often be forgotten when from the physician end to be thinking about all the things that they're going through and all the different interactions that they have. And also to add that the Vision Academy website, as you suggested, has got some really, really useful tips and advice and some really useful questions. And I would urge physicians or carers of patients with diabetes to look through that website for that guidance.
Just while you're there, Tariq, I do have a question to ask. Manfred asks, can you recommend DR promotional materials focusing on vulnerable populations? And perhaps this is a webinar that we need to have in the future. You know, vulnerable populations, those with low health literacy, those with disabilities or ethnic minorities. Have you had experience working with those subpopulations?
Well, I do have, I work in Manchester, so we do have a lot of people from ethnic minorities here. We have all of the diabetic retinopathy leaflets and information that we give is translated into a variety of different languages. There is we've possibly got some further work we need to do in terms of disabilities. That may be, and low health literacy. I think we probably need to address those a bit further, but that's a useful comment that maybe we should take back to the Vision Academy actually and think about that further.
I think that would be great. And Manfred has said a separate webinar would be fantastic. So I think that we're on to something. Professor Zaimson, what's your single most important message?
I think our experience was just try it. So not every did work as we first thought it might work, but by listening to the reaction to our posts and also listening to the audience, we really achieved to improve the quality. And maybe also with regards to your last question for vulnerable populations or low health literacy, not everybody of our patients have to become an expert. So we have also to think of other modalities just to get the people involved and just to get them motivated. And we have to accept that this is not one approach for all, but an individualized approach.
Look, thank you very much. I'm always curious, interested, and left with not many words to say when I'm listening to experts, clinicians that are working with people and patients every single day. Professor Zaimson, you know, you've given us some advice who are working on the DR Barometer to also take, and that's to listen to reactions. Not everybody needs to be an expert. And we have to refine our approach constantly. So I thank you for those closing words. To wrap up, I want to thank Michelle, Tariq and Foka for being with us today. We are trying, we are experimenting. So your comments are really important for us to then explore what other webinars that would be of interest, informative and helpful to build the capacity of others. So in closing, I want to thank the speakers, but most importantly, the IFA staff who have been working tirelessly. So Yifan Zheng and Anna Sangster, thank you. And just to close up, the IFA will be having a presidential symposium on vision health in Niagara. So we welcome you to be part of this, but to continue to be part of this very important conversation. You know, our job is to improve vision health of people around the world and to really be part of that conversation that prevents people with diabetes from ever having diabetic retinopathy. So thank you very much for your attention, and we welcome your comments and criticisms and positive ways forward. Thank you.
Thank you, Jane. Thank you everyone for attending.
Thank you.